Good evening, everyone. My name is Dr. Annette Joyce, and this seminar is called Clearanail, A New Beginning for Podiatry, Your Questions Answered. So the first question of the evening is, what's in the news today? We've had many interesting media events in the last year since Clearanail was launched in the United States. The start was an article in JDD, the Journal of Drugs and Dermatology, in a special psoriasis issue, where we had a key feature article by Dr. Ivan Bristow and Robert Baran. We've also been featured in media outlets such as Nails Magazine and Practical Dermatology, and of course, Meet the Masters, where Dr. Rabotsky talked about Rolf Thomas, Joel Morse, and Annette Joyce, myself, in microdrilling as a new treatment for onychomycosis. Patients are asking for this new technology. As you can see on the media and the internet, there are many articles now talking about microdrilling, such as one that was recently in Practical Dermatology, specifically oriented toward dermatologists, talking about this brand new smart drill technology that first became available from Europe in June of 2016. And next month, we will be happy to see an article in Podiatry Management, How to Thrive in a Down Economy. This is just an example, but it's called Emerging Technologies in Nail Disease, Microdrilling, A New Beginning by Dr. Dieter Feltner. So how about the science? Everyone's concerned, do microdrills actually work, and are they the right treatment for onychomycosis? So this is the original article that I just talked about in JDD, presented by Dr. Bristow and Dr. Baran. And this article is a proof of concept with several case studies followed over a 6 months timeline. The reality with microdrilling is that it's the most important in a combination therapy for onychomycosis. So we all are tending to tell our patients that they are going to use not only one treatment modality, but 2 or 3 to prevent resistance with onychomycosis. Certainly, it's nice to give everyone a pill, but it doesn't always work, and it's not always practical with drug interactions and concerns with liver function. So patients will want a topical, but we know it's really hard for topicals to get to the nail. So combination therapy is the most widely accepted method of treating onychomycosis today. This is some pictures from this article. Just briefly, you can see the small keratinized holes in the nail drilled by the Clearanail product, creating 0.4 millimeter micro pores in the nail. And what happens commonly after drilling this nice pattern of holes is the nail and the dermatophytoma, the fungus, will actually collapse from the nail and fall out in some areas. And this is a 6-month follow-up picture. More case studies, nail day 1 here, 3 months and 6 months, day 1, 3 months and 6 months out. I always think the pictures tell the whole story. This was a very well done article with Dr. Gupta. And again, Dr. Baran is in here as well. It's a 3-arm treatment group where patients were assigned either Lamisil pulse dosing for 2 weeks plus drilling, which was group 1. Group 2 was Lamisil spray, which is an alcohol-based over-the-counter spray plus drilling. And group 3 was just spray only, which in theory would be placebo with no intended effect on nail. You had 98 patients participating, and which I like about this study is Dr. Gupta broke it down into less than 50% and greater than 50% involvement, which would be the moderate to severe cases. He had about 60% in the mild to moderate, and he had 38.7% in the moderate to severe. And his statistics, these patients were followed out for 6 visits over a 6-month timeline. Group 1, of course, performed the best with the pulse dose Lamisil plus the microdrilling. Group 2, followed out for Clearanail, still did very well. That is the group that had the spray Lamisil plus drilling. And group 3 was just spray only. This is the more severe cases here, the 51 to 75% involvement. You see the numbers come down, but you still see some excellent clinical results. Dr. Gupta also determined mycological cure by visit. By group 3, he checked for by visit 3, he checked for mycological cure in the groups. At visit 6, which was 6 months out from the original treatment, you saw a 47% mycological cure in group 1, which was pulse dose Lamisil plus drilling. Group 2, a 34% cure rate with Lamisil spray and drilling, and then almost none or a much insignificant amount with just spray only. So if we asked ourselves, why does microdrilling work? I think this article was one of the first studies to talk about what happens when you create holes in the nail. And I like this theory as to why we are seeing an immediate and dramatic change in the nail. This is a fractional CO2 laser. These units are very expensive. They're commonly owned by dermatologists for skin resurfacing and microdermabrasion. Very few of us as podiatrists will own these machines. However, the mechanism of action was proposed in fractional CO2 lasers, which are, again, they're breaking down the nail. They're creating holes in the nail, very similar to microdrilling, in order to penetrate with a topical antifungal. They hypothesize here that the tissue ablation process induces direct fungicidal effects, and multiple columns created by the holes in the nail enhance the penetration of topicals into the nail bed. We all know we need to get to the nail bed and preferably even the nail matrix to eradicate fungal nail disease. And I think that the idea of microdrilling and fractional lasers just tells us that there's a theory of action here that we're not even certain, but we know it has a dramatic effect on the nail bed. This is a picture of a CO2 laser just to compare. You know, it creates many, many holes in the nail, but it also can damage and cause hemorrhaging. It does require anesthesia when you do lasers of the nails in this manner. Let's talk a little bit about lasers. This talk tonight is not about laser treatments, but I have many doctors over the last year ask me, can you still use lasers with microdrilling? And I think that there certainly are, you know, podiatrists that believe lasers are effective for onychomycosis, and there's many that do not. And so I think Clearanail or microdrilling is an adjunct to laser treatment. I think it can be used concomitantly. As we talked about, combination therapy is important, and I think you use everything you can to get patients better with onychomycosis. But this study was, this is just an informational article that was published about if lasers actually work. And there was a study with a pinpoint 1064 type ND-YAG laser, randomized controlled study. It didn't have a lot of patients, had 20 patients with 82 nails. No patients received a mycological cure. So many of the early laser studies never had mycological cure as an endpoint. And I think with today's science and today's peer-reviewed literature, we'd like to see more studies with endpoints of mycological cure. So lasers aren't necessarily a single treatment option or monotherapy for nail disease, but they could be used as a combination. And we'll talk about that when we get to patient protocol about microdrilling and lasers. So question number 3, what have we learned about the nail as a unit? And I will say this, in the last 7 years that I've been lecturing on nail disease, we have learned a lot in the last 2 years. There's been some dramatic changes in understanding how the nail functions as a barrier and a protective unit for the nail bed. We know that pharmacy has certainly created some products for us. We are seeing new prescription topicals in the last few years that we hadn't seen in a long time. Even potentially a new oral antifungal will be available to us. It's in phase 3 right now. But pharma has spent roughly $45 million in clinical trials just to get these pharmaceuticals to our offices. And what they have to understand is how to get through the nail plate. And so that seems like a large number just to figure out how to get into the nail bed and the nail matrix. Remember, the nail bed acts as a reservoir. We continually go back to this theory that the nail bed itself is creating and maintaining an environment for the nail plate. And so the two work together and continually reinfect each other when you have a concern for fungus or whether it be another type of bacterial infection in the nail. I hate to say this, but I think our colleagues still are seeing nail avulsion as standard of care for dystrophic nails since the beginning of time, since the beginning of podiatry. I still have patients come in with 10 nails removed as a treatment for fungus. And I kind of cringe when I see that because most patients do not want all of their nails removed as a treatment for nail disease. I think that it has a place, and certainly there are times that nail avulsion is necessary. But as a treatment for onychomycosis, I would discourage it. Fractional lasers, we talked about those. They're creating microconduits, very similar to microdrilling. That was most likely where this theory came from. And remember, we're just beginning to understand the physical properties of the nail as a unit. This was a very interesting article on transilnikial water loss, and it showed 3 products that were different in molecular weight and size and ability to penetrate the nail. And they took healthy nail and diseased nail, and they measured something called transilnikial water loss, or TOWL. So the 3 drugs were caffeine, amorpholine, and terbinafine. Caffeine is a very lightweight drug. Amorpholine is a topical antifungal used in Europe. And terbinafine, believe it or not, as a molecule is a very heavy drug. It cannot get through the nail readily. They took and put these drugs into a chamber and tried to replicate the nail and how it penetrates into the nail itself. And of course, the low molecular weight, hydrophilic, the water-loving molecules got through the nail more readily. The high fat concentration, such as creams or oils, cannot get through the nail as readily because the lipid content in the nail is lower than in the skin. And remember, nail is a porous, hard keratinized network, and it requires special opportunities to get through it because it's protecting the nail bed. Also, we know surface tension impacts spreading. If you notice, many of your topicals have an alcohol proprietary formula. And alcohol is a very low surface tension, so it's able to get across the nail and wick and spread very quickly. So this is a picture just kind of showing the nail as an environment. Remember that water balance and respiration is key to nail disease. So we don't want the nail to be too wet. We don't want the nail to be too dry. Both of those environments will promote infection. And so transilnikial water loss, that proper maintenance, the nail homeostasis, is what we need in order to encourage, or I should say discourage, infection and encourage proper hygiene and management of nail disease. So number 4, how does microdrilling actually work? It creates micro pathways, multiple columns in the nail. It enhances the penetration of topicals. I always tell patients the drill itself is not necessarily going to do anything to your nail, but the choice of topical and you using it every day is what's going to make the difference in nail disease. Remember the process of deep tissue stimulation we saw with CO2 lasers. We know that by creating holes in the nail, we're changing the environment. We used to avulse nails to change the environment. Well, now we're creating pores that are very cosmetically pleasing, they're non-painful, and the patient likes those results almost immediately. We can maintain that proper water environment, that transilnikial water loss. That allows for an immediate cosmetic improvement, which is really what we're looking for with patients, is to see a cosmetic change in that nail as quickly as possible. It allows direct access to the matrix. We can get very close to the matrix of the germinal matrix, which is the lunula area. We can get into that area. We also can take a sample of subungual debris. So if you prefer to take a very deep culture for biopsy, you're able to do so by drilling a hole into the deepest part of the nail and getting debris for your culture bag. It's non-ablative. Unlike lasers, it does not generate heat. So this does not cause any nail damage or pain or insult to the patient. This is a picture of the nail itself, of course, and what we really have a problem is getting into this area. We can't get medicines here very readily. Avulsing the nail, sometimes, we try to get medicine in that way, but what if we could just put some holes in the nail and have the same effect? This is as simple as it gets for a treatment or for a medical device. You take a toenail, you take a microdrill, you put some holes in it, and then you have the patient choose a topical with your recommendation. There is a very excellent 2.5-minute video on Vimeo.com, and you can type foot.preneur.com, and there's a link, and it just shows the different components of a microdrill, how to get started. It takes 5 minutes to turn this machine on and get started. So it's a very simple, easy to use process. I encourage everyone to take a look at that. What can my patients expect? Patients should always sign an informed consent. No matter what medical procedure I'm doing, even injections, I have patients sign informed consent. It's part of the marketing package. With Clearanail, you will receive informed consents and patient instructions. You can tell them they might feel a brief pricking or stinging sensation in a thinner nail. If a nail is very thin or crumbly, I always caution putting the microdrill in a too thin area. It should not be used for fingernails. If a patient's on a blood thinner or has vascular disease, you want to consider whether that's a risk to the patient. Patients must use antifungal and antimicrobial spray, again, twice a day. Why I say antimicrobial spray is because This treatment can deliver any drug into the nail bed, so you do not have to use it simply for an antifungal modality. You can use it for an antimicrobial or even a steroid if someone had maybe a psoriatic nail or a reason you would want steroid under the nail. So these are other treatments that you can use with microdrilling. You want to explain your protocol for preventing infection. We know that about 50 to 60% of onychomycosis comes back. It's very resistant to treatment. So of course, proper hygiene, skin treatment, and nail care should be explained to the patient. And finally, I always tell my patients nails grow very slowly, only about 0.5 millimeter a month. So be patient with us because this is going to take time as new nail grows in. This is just a simple example of how you would drill the nail. I always say less is more. You don't need to put 100 holes in the nail. On a hallux nail, I might average anywhere from 15 to 20, depending on the width and size of the nail. A lesser nail, maybe 5 to 10 holes. It's coined firewall technique because you want to trace the active infection. So if you only had this streak here, you would just put some holes along that area. You always want to stay somewhat distal to the lunula to avoid damage to the nail bed or to have a bleeding issue. So I try to stay somewhere distal to the lunula. This is some results from Dr. Bristow's blog. I love the high resolution photos because I think they tell that story. This is a pretty horrific nail. He calls this a tri-stripe nail. And it really was something that was moderate to severe case that he didn't expect to get results from microdrilling. This, you can see the holes very nicely into high resolution. They were drilled right through the area of infection. Also, there's some holes drilled in this area. This is week 12. This is week 20, already seeing some nice new clearance of nail. None of the distal nail was trimmed, so you can see the evolution of the disease. And this is at week 35, where to me, once you trim away this dead nail, for this to be a little bit past 6 months out, this is a very healthy nail compared to where we started. So remember, with a foot hygiene program, I always tell my patients that treating fungus is a lifetime commitment. We can't cure fungus. There is no way to do so at this point, but we need to encourage patients to continue with foot hygiene, spraying their shoes, treating their tinea, basically pedicure, safety. And remember this, if you think about prescribing topicals for patients, that there's studies out there that say compliance actually decreases the longer we use prescription medicine. So it's obvious patients will put it on very diligently in the beginning, and as time goes on, they just don't use those topicals as daily recommended as we would like. So by adding a modality such as microdrilling, hopefully we're encouraging patients to stay on their medicine and see results in a quicker timeline. Everyone asks me what topicals do I use, and I guess the question is, what topicals don't I use? I have tried almost every topical out there. I tend to stick with the standbys with the studies. A Lamisil spray, which is a terbinafine-based alcohol spray, is readily available and over the counter. I know that many companies now are mimicking the content of this to the extent that they can, because we are asking for non-oil based solutions. So remember, the most important thing is not to use creams, oils, or polish. All of 3 of these things, if you're going to do microdrilling, are going to clog the holes or prevent the translanicular water loss. So you really want to prevent or not use anything that's thick, fatty, heavy oils or polish. All these products here I've used in my practice, they do not have those ingredients that I'm concerned about. What can the doctor expect? We're going to do all this work, we're going to bring our patients in, and of course we want our patients to get better, but what can we expect on the practice management side? I will say that microdrilling is probably one of the easiest modalities I have entertained in my practice, and I've had a lot of different technologies and lasers. It's very simple to set up, very simple for staff to understand. It's very basic for patients as well. I always tell patients, we're going to create some micro pores in your nail. You're barely going to be able to see them, and you're not going to feel them. And the reason we're doing that is to get the medicine to where it needs to be to do the work. Hopefully you won't have to stay on medicine as long. We know that sometimes insurances don't pay for these medicines as readily, and so patients appreciate that. This is a very affordable process for patients. Many clinics are doing what we call antifungal maintenance, where patients pay a flat rate and they can be seen as many times as needed up to a year. So you can create a contract with a patient, give them an annual maintenance plan, and say this is what you're going to get for a year time, knowing that fungus tends to come back or nail disease can reoccur. So the other possibility is to charge per toe. Remember, in theory, this can be done one time because the holes are permanent until they grow out. So it's not something where they have to come in every 2 weeks, every 4 weeks, like they might have to do with lasers. This is a very quick and easy process. Just be certain they're staying on their antifungal remedy or the medications prescribed by you. And it's important when you take the phone call, I always train my staff to remind them this is an aesthetic service. It's not covered by your health insurance. I think if you set that realistic expectation up front, patients appreciate it. You will receive practice marketing materials. I have used all of these in my practice, on my website, in the media, as an outreach. I think these are very useful. Certainly, if you need something specifically, we use a group called 10 Toes Marketing, run by Sarah Braymeyer, and she can tailor anything to your needs. So I think that there certainly is many marketing activities out there that will benefit your patients in your practice. Remember that we have microdrills in almost every state in the United States at this point, but there's still opportunities for centers of excellence. And that means that your specific area would receive referrals via online referral and marketing to help promote microdrilling in your town. There's leasing. I always leave this to David because David is the sales executive. He will talk to you about qualifying for leases. Of course, these are very affordable machines. Many doctors just purchase them. Your annual return on your investment is up to you. It depends on how many patients you see and really just recommending this. I think it's important to give patients a treatment option. You know, Mrs. Smith, you have this concern with your nail. These are the options I am offering you today. I always try not to judge the patient and what they can afford, but give them their options and let them make a choice. This is a Center of Excellence certificate. Again, there are still areas that are underserved with microdrilling, and you're certainly welcome to call and discuss that further. Being the first is always important. And this is our contact information. I'm Dr. Joyce. That's my cell phone and my email address. I have David Zuckerman. If you want pricing or leasing or are interested in making a purchase, this is the time. And then Sarah Braymeyer, she's an excellent marketer. 10 Toes Marketing can help with any of your marketing needs.